सभी को मेरा नमस्कार। विश्व आयुर्वेद परिषद की ओर से आयोजित इस प्रत्येक शुक्रवार की अनवरत व्याख्यान माला में मैं आप सभी का तहे दिल से हार्दिक हार्दिक स्वागत करती हूं। और आज का व्याख्यान शुरू करने से पहले जो आज के व्याख्यान का अपना टॉपिक है, अंडरस्टैंडिंग इंडोमेट्रियोसिस डिसीज ऑफ डायलेमा। बिल्कुल सही है, ये डिसीज ऑफ डायलेमा है। और मैंने यूट्यूब के ऊपर बड़े सारे मॉडर्न डॉक्टर्स के वीडियोस जो सामान्य पेशेंट की भाषा में उनको समझा रखे हैं वो सुने, और सही में उन्होंने बहुत अच्छा प्रयत्न भी किया है वहाँ। तो मुझे ऐसे लग रहा था कि एज पर आयुर्वेदिक पर्सपेक्टिव हम आयुर्वेद के टीचर्स को और चिकित्सक को आगे आना चाहिए इन रोगों के बारे में आयुर्वेद का पक्ष बताने के लिए, कि आयुर्वेद के अनुसार हम किस तरीके से क्योंकि बहुत सारे पीयर रिव्यूड सक्सेसफुल आर्टिकल्स है, तो अगर हम सामान्य लोगों तक ये बात पहुंचा देते हैं या पहुंचाने में हम कामयाब रहते हैं, तो ये कहीं ना कहीं डिसीज ऑफ डायलेमा आयुर्वेद के लिए मुझे लगता है कि नहीं रहेगा। हम उसकी वायु की चिकित्सा करके वहां बहुत अच्छे रिजल्ट ले सकते हैं। तो आज के व्याख्यान को शुरू करने से पहले आज के व्याख्यान के व्याख्यानकर्ता प्रस्तुतकर्ता का मैं सबसे पहले आपके सामने परिचय रखना चाहूंगी। आज के जो अपना स्पीकर्स है उनका नाम है डॉक्टर प्रियंका टी.के, एसोसिएट प्रोफेसर एंड हेड ऑफ द डिपार्टमेंट ऑफ MVR आयुर्वेदा मेडिकल कॉलेज, पारासीनिका डावू, कन्नूर, केरला से अभी वर्तमान समय में आप वहाँ कार्यरत है हेड ऑफ द डिपार्टमेंट के पद पे। आपने अपनी BMS की पढ़ाई NAMV अर्नाकुलम केरला से पूरी की है 2011 में। इसके बाद आपने एडवांस डिग्री कोर्स और सर्टिफिकेट कोर्स भी किए हुए, जिनमें से इंस्टीट्यूशन STMCA उडुपी ईयर ऑफ 2016, डिसर्टेशन क्लिनिकल इवोल्यूशन ऑफ द प्राकृत एंड विकृत गर्भावस्था यूजिंग गर्भ स्पंदनम मानी fetal heart sound and the fetal movement under the valuable guidance of Professor VNK Usha Madam, former Dean and head of the department STM College of Ayurveda उडुपी में आप तभी थे और उनके गाइडेंस में आपने काम पूरा किया है। एडवांस सर्टिफिकेट में आपने सर्टिफिकेट कोर्स इन पंचकर्म कोट्टकल से, एडवांस सर्टिफिकेट कोर्स इन द रिसर्च मेथोडोलॉजी फ्रॉम द केरला यूनिवर्सिटी ऑफ हेल्थ साइंसेज, एवं एडवांस सर्टिफिकेट प्रोग्राम ऑन डाटा एनालिसिस यूजिंग द SPSS IAS कानपुर 2024 में आपने पूरा किया है। अभी वर्तमान समय में जो आप कार्यरत है वहाँ आपका टोटल एक्सपीरियंस मोर देन 8 इयर्स का है। आपकी रिस्पॉन्सिबिलिटी अभी एकेडमिशियन की, क्लिनिशियन की और एडमिनिस्ट्रेशन की भी भूमिका में है आप। एरिया ऑफ एक्सपर्टाइज आपका है प्रसूति तंत्र एवं स्त्री रोग, आयुर्वेदा ऑब्स्टेटिक्स एंड गायनेकोलॉजी में, स्पेशली गायनेकोलॉजिकल डिसऑर्डर लाइक PCOS एंड इंडोमेट्रोसिस, जो वर्तमान समय में सबसे ज्यादा भारतवर्ष में एक मुश्किल के रूप में हमारे सामने आया है, और दोनों में आपका बहुत अच्छा एक्सपर्टाइज है। एवं सूतिका परिचर्या, आपने 3 पब्लिश्ड आपकी बुक्स है, और आपकी बहुत सारी और जगह भी जो एकेडमिशियन के रूप में आपकी भूमिका रहती है, और नो डाउट हेड ऑफ द डिपार्टमेंट है तो वहाँ भी आपकी प्रशासनिक सेवाएं भी कहीं ना कहीं महत्वपूर्ण भूमिका में है। सभी पार्टिसिपेंट्स को मैं एक और भी बात बताना चाहूँगी कि मैडम के साथ मेरी लगभग 2.5 से 3 महीने पहले आज के व्याख्यान के लिए बात हुई थी, और अभी उनकी कॉलेज में इंस्पेक्शन है, और मैं समझ सकती हूँ क्योंकि राष्ट्रीय आयुर्वेद संस्थान में इंस्पेक्शन है, हम इतने ज़्यादा स्टाफ मेंबर से, उसके बावजूद भी बढ़िया से बढ़िया मार्किंग हो, अच्छा लगे, कहीं भी एक भी ऑर्डर या रिकॉर्ड में कहीं कमी ना रह जाए, ऐसा सब देखते हुए बड़ा ध्यान देना पड़ता है। और आप तो हेड ऑफ द डिपार्टमेंट हो, उसके बावजूद भी आपने जो हमसे कमिटमेंट करी थी कि यू विल डिलीवर लेक्चर ऑन 20th जून, आपने वो अपना वचन बरकरार रखा और बहुत बहुत अग्रिम धन्यवाद, क्योंकि बहुत बार ऐसा नहीं भी हो पाता, मगर आपने एक अच्छे एडमिनिस्ट्रेटर की भूमिका ये भी बता रही है कि आपने इधर वाली भूमिका भी बिल्कुल यस करी और वहाँ की आपकी बिल्कुल बढ़िया है। तो बहुत ही बढ़िया है और मुझे लगता है कि जरूर जो आपने अपना रिसर्च किया है वीएन के उषा मैडम के गाइडेंस में, वहां से भी आपने बहुत प्रेरणा ली होगी, क्योंकि मेरा पहला एक अनुभव या मिलना उनके साथ दिल्ली में, न्यू दिल्ली में अय्या में उत्तर बस्ती के ऊपर एक वर्कशॉप था, तब हुआ था। मैं मैडम को जानती नहीं थी, मगर मेरे पेपर प्रेजेंटेशन के बाद मैडम ऐसे ही चाय वगैरह पीते समय वहाँ हमारा नमस्ते हुई और मैडम ने मुझे कहा, हेतल तुमने अच्छा बोला। तो ये मेरे लिए शब्द इतने ज्यादा मायने रखते हैं ना, कि मेरी मृत्यु के एक क्षण पहले भी मैं उनके लिए कृतज्ञ रहूंगी कि बिल्कुल नहीं जानते हुए भी एक न्यू कमर की सराहना करना, उसको आगे वाला पथ को प्रशस्त करना, जिससे उसको और काम करने की प्रेरणा मिले। क्योंकि मैंने मैडम का व्यक्तित्व अनेक लोगों से सुना है और वो उन्होंने मेरे जीवन में चरितार्थ किया। आज मैडम हमारे पास इस दुनिया में नहीं है। मैं उनको सादर प्रणाम करती हूँ और आप जैसा व्यक्तित्व मुझे लगता है कि ईश्वर के पास भी जरूरत होती है, तो आपको उधर बुला लिया और आप सही में महान विभूति है। तो मैं एक बार फिर से प्रणाम करते हुए आज के लेक्चर के लिए डॉक्टर प्रियंका जी आपको आमंत्रित करती हूँ अंडरस्टैंडिंग ऑफ एंडोमेट्रियोसिस को प्रेजेंट करने के लिए। ओवर टू यू।
Thank you, madam, for the warm introduction. Good evening, everybody. First of all, I would like to thank Dr. Hetal madam for giving me an opportunity to share this platform as 508th lecture of the Vishwa Ayurveda Parishad's study circle, engaging with esteemed faculties and practitioners and students dedicated to advancing Ayurvedic knowledge. Thank you so much, madam, for this opportunity. And I also extend my heartfelt respects to all the faculties and experienced practitioners present here. And I welcome you all for today's lecture on the topic, Understanding Endometriosis, a Disease of Dilemma. Yes, it is considered as a disease of dilemma because of its complex pathology, varied symptomatology, and persistent recurrence in spite of intervention. So here, this condition actually continues to be a challenge to modern practitioners. Ayurveda, with its profound understanding of dosha dynamics, can provide unique perspectives in managing this condition. So through today's lecture, we'll explore how Ayurvedic principles can be effectively integrated to optimize patient outcomes, mitigate the recurrence, and improve the reproductive health. Before delving into the topic proper, with deep sense of gratitude, going head before all my gurus at STMCA Udupi, especially my PG guide, late Professor Dr. Piyanka Uchama, former Dean and HOD, Prasutandra Department, and she was the founder president of Kagov too, whose contributions to Prasutandra Triroga remain so valuable. And expressing heartfelt gratitude to my mentor, Dr. Mamta ma'am, principal of STMCA Udupi, whose unwavering commitment to patient care and her Ayurvedic wisdom has also personally inspired me. And it's through witnessing the transformations of her patients that my own faith in the depth and precision of our science has been deeply reaffirmed. Moving on to the topic proper, this is the structure of my presentation, Understanding Endometriosis, along with Ayurveda perspective with a case study. By definition, it's the presence of endometriosis is the presence of functioning endometrial glands and stroma outside the uterus. It may develop anywhere, either within the pelvis or on other extrapelvic peritoneal surfaces. Most commonly, it's found on the dependent areas of pelvis, the ovary, pelvic peritoneum, pouch of Douglas, uterosacral ligaments. These all are frequently involved. Additionally, rectovaginal septum, ureter, bladder, surgical scars, and even the distant sites like pleura and even brain may get affected. Moving on to the prevalence, actually this is found predominantly in women of reproductive age, but it's also reported in adolescents and in postmenopausal women receiving HRT, and the prevalence is assumed to be around 10% of women of reproductive age. But in actual, there may be huge numbers of undiagnosed cases. Actually, many women with endometriosis may not be seeking medical help due to a variety of reasons, maybe the lack of awareness or maybe some stigma surrounding periods. Or not only that, the diagnostic confirmation of endometriosis actually required direct visualization on laparoscopy or laparotomy, which is not being done so commonly due to many factors like the invasiveness of the procedure and all. So these all are actually increasing the load of undiagnosed cases. Regarding risk factors, early aged menarche, shorter menstrual cycle length, hypermenorrhea, nulliparity, Mullerian anomalies, low birth weight, that is less than 7 pounds, that is less than 3 kg weight, red hair being one of the multiple fetal gestation, PES exposure, endometriosis in first degree relative, tall height, dioxin exposure, a diet high in fat and red meat, and even prior surgeries or medical therapy for endometriosis, that is also a cause for a risk factor for its recurrence. Here all we can see that estrogen exposure is seen, and endometriosis itself is an estrogenic disease. So exposure to estrogen can contribute to development of endometriosis. Now, with regard to protective factors, they include multiparity, lactation, increased body mass index, increased waist to hip ratios, and diet high in vegetables and fruits. Now, when we look into the etiopathology, this endometriosis, it's considered as a disease of theories, because no single theory can account for the location of endometriosis in all cases. Coming to the most accepted theory of retrograde menstruation, it's otherwise called as transplantation theory. It was put forward by Sampson, and is based on the assumption that endometriosis is caused by the seeding and implantation of endometrial cells by transtubal regurgitation during menstruation. Here what happens is the refluxed endometrial fragments will adhere and invade the peritoneal mesothelium. There they'll develop a blood supply, and it will lead to continued implant survival and growth. And studies say that uterine hyperperistalsis and dysperistalsis have been noted in women with endometriosis. And this might have resulted in subsequent increased endometrial reflux in cases. But later, scientists discovered that this retrograde menstruation appears to be a common event in women, but not all women who have retrograde menstruation are developing endometriosis. Then they landed to a conclusion that the immune system may be altered in women with endometriosis. And it's hypothesized that the disease may develop as a result of reduced immunological clearance of these viable endometrial cells from the pelvic cavity. Usually, these menstrual tissues and endometrium, which is refluxed into the peritoneal cavity, may be cleared by the immune cells, such as natural killer cells, macrophages, and lymphocytes. You know that natural killer cells, they have a cytotoxic activity against all the foreign cells. So here, a decreased natural killer cell cytotoxicity against the endometrial tissues has been demonstrated in studies. and even macrophages, which are the scavenger cells in various tissues, appears to be impaired here. In spite of their increased numbers, it can lead to decreased clearance of this peritoneal fluid endometrial cells, resulting in further endometrial proliferation. Another one is cytokines, which are involved in paracrine and autocrine signaling of other immune cells. There is an increased level of interleukins, especially interleukin 1, 6, and 8. These are found to be increased in the peritoneal fluid and can stimulate the proliferation of endometrial stromal cells. TNF alpha, tumor necrosis factor alpha, is also found to be increased and may facilitate the pelvic implantation of this ectopic endometrium. There, the growth of endometrial cells is further promoted by the secretion of other non-interleukin cytokines and this growth factors, angiogenetic factors such as EGF, VEGF, MDGF, fibronectin, and adhesion molecules such as integrins. Now, seeing this, we can understand that endometriosis is always associated with a state of subclinical peritoneal inflammation marked by an increased peritoneal fluid volume, increased peritoneal fluid WBC concentration, and increased inflammatory cytokines, growth factors, and angiogenesis promoting substances. And some research studies say that this subclinical pelvic inflammatory status will also be reflected in the systemic circulation. So there you can see an increased concentration of CRP, serum amyloid A, TNF alpha, membrane cofactor protein 1, interleukin 6 and 8, chemokine receptor 1. These all can be observed in peripheral blood samples of endometriosis patients. Now, with respect to humoral immunity, this is also shown to be altered in affected women and is suggested to play a role in the development of endometriosis. Because endometrial antibodies of IgG class are frequently detected in cases of endometriosis. So, one study has identified IgG and IgA autoantibodies against the endometrial and ovarian tissues in the sera, as well as in cervical and vaginal secretions of affected women. Now, what are these results suggesting? That means endometriosis may be in part an autoimmune disease, right? Although this endometriosis has not been classified as an autoimmune disease, there are several resemblances with autoimmune disorders. And the resemblances include increased cytokines, reduced cell apoptosis, and abnormalities of T cells and B cells. A study was conducted in 2022 at ICMR, Mumbai, investigating the autoimmune etiology of endometriosis in Indian population, whereby using the proteomics approach, anti-endometrial antibodies were detected in Indian women with endometriosis. And the anti-endometrial antibodies include tropomyosin 3, stromatin-like protein 2, and tropomodulin 3. Even though it is not officially declared as autoimmune, maybe in near future, we may witness that too. Moving on to the induction theory. This theory proposes that some hormonal or biological factors may induce the differentiation of undifferentiated cells into endometrial tissues. We all know that estrogen is one of the causative factors that has been definitely established in the development of endometriosis. In vitro studies have also demonstrated the potential of ovarian surface epithelium in response to estrogens. These can undergo transformation and form endometriotic lesions. And here we know that the enzymes aromatase and 17-hydroxysteroid dehydrogenase type 1. These enzymes are responsible for the conversion of androstenedione to estrone and estrone to estradiol. But these enzymes are not present in a normal endometrium. But whereas in a ectopic endometrium, due to the local inflammation and secretion of prostaglandins and all, these enzymes get expressed, suggesting that the ectopic endometrium produces estrogens. In addition to this, a normal endometrium has elevated levels of 17-hydroxysteroid dehydrogenase type 2 in response to progesterone, which ensures that estrogenic effects are attenuated in response to progesterone. But whereas in ectopic endometrium, the ectopic endometrium is deficient in 17-hydroxysteroid dehydrogenase type 2. So this enzymatic combination, that is the expression of aromatase and 17-hydroxysteroid dehydrogenase type 1 and the deficiency of the same type 2 will keep the implants exposed to an estrogenic environment, resulting in further endometrial proliferation. So this is one among the induction theory. Then moving on to the theory of coelomic metaplasia. This theory states that the transformation of coelomic epithelium, means metaplasia of coelomic epithelium into endometrial tissue, is the proposed mechanism for the origin of endometriosis. The theory suggests that parietal peritoneum is a pluripotential tissue that can undergo metaplastic transformation to tissues which are histologically indistinguishable from a normal endometrium. Because the ovary and the progenitor of endometrium, the Mullerian ducts, are both derived from coelomic epithelium, this theory of metaplasia can explain the development of ovarian endometriosis. In addition, the theory can be extended to include peritoneum too because of the proliferative and differentiation potential of the peritoneal mesothelium. But however, the absence of endometriosis in other tissues derived from coelomic epithelium argues against this theory. And next one is the development of endometriosis in unusual locations like distant sites and all. No, these all are attributed to the lymphatic spread or vascular spread. Actually, when we look into the tendency of this endometrial adenocarcinoma, no, it can spread via the lymphatic route. So this can indicate at the ease at which the endometrium can be transported by this route. Coming to the role of genetics and environmental factors, endometriosis is a complex disorder caused by a combination of multiple genetic and environmental factors. It is said that the risk of endometriosis is 7 times greater if a first degree relative is affected by endometriosis. Because no specific Mendelian inheritance pattern is identified, a multifactorial inheritance is postulated. And large genome-wide linkage studies have identified 3 linkage regions of endometriosis on chromosome 10q26, chromosome 20p13, and chromosome 7p13-15. Actually, these the genes here described, these have linkage regions which have roles in estrogen metabolism. Next, coming to the role of environmental toxins. Dioxin exposure is a risk factor for development of endometriosis. Dioxin, it is an environmental pollutant, actually mainly originating from the garbage incineration and metal processings. Due to its lipophilic nature, it tends to accumulate in the food chain, making contaminated foods as a primary source of human exposure. And studies suggest that this dioxin exposure may contribute to endometriosis development by activating the aryl hydrocarbon receptor, which is a transcription factor similar to steroid hormone receptors, leading to gene transcription. And this activation may promote endometriosis by increasing the interleukin levels, contributing to inflammation. and activating the aromatase enzyme, influencing the estrogen metabolism, and even altering the tissue remodeling, leading to the ectopic endometrial proliferation and growth. Then moving on to the appearance, we can categorize the endometriosis into three forms based on its appearance. It may either appear as endometrial implants, or may appear as endometrial nodules, or maybe endometriomas. Now, what are these endometrial implants? These implants are actually appear like tiny dots or clusters of dots that lie on the surface of the peritoneum, covering the ovaries and the organs of the pelvic cavity. They usually 1 to 2 mm in diameter, and it can vary in color from red to black and white, depending on their stages. These are the various types of implants. The red implants are young implants made up of endometrial cells that are only recently implanted within the pelvic cavity. These are actually active implants because they undergo regular cycles of growth and bleeding in response to hormones and are indicative of early endometriosis. Whereas black implants are older implants which have undergone many cycles of growth, bleeding, inflammation, and scarring, and are indicative of advanced endometriosis. But they are said to be less active implants because they do not undergo such regular cycles of growth and bleeding in response to hormones. And white implants, probably these are the remnants of old implants that have healed or are inactive. Second is it can appear as nodules. Nodules actually appear on uterosacral ligaments, the pouch of Douglas, or maybe the tractovaginal septum. These have got a different structure and appearance. These are usually elliptical lumps rather than flat-like implants. These are often hard to see because they tend to lie under the peritoneum or infiltrate deep into the underlying tissues. In fact, these nodules are often more easily palpated during a pelvic examination than seen during a laparoscopy. Next is endometrioma. Oma means mass. So here what happens is there is endometrial cyst, which is called as chocolate cyst. They are larger than implants and have got a fibrous wall around them. Usually they are 4 to 5 centimeter in diameter, but it can range from 1 to 10 centimeters to commonly referred to as chocolate cyst. Moving on to the classification by American Society of Reproductive Medicine. The classification is done on the basis of morphology, which includes red, black, and white lesions, the size and the depth of peritoneal implants, presence and extent of peritoneal adhesions, and the degree of cul-de-sac obliteration. Here we can see the different stages of endometriosis. Stage 1 is minimal. Here there are only isolated superficial implants and no adhesions. Stage 2 is mild, having more superficial implants but less than 5 centimeter in size and no significant adhesions are seen. Stage 3 is moderate, having multiple superficial and invasive implants. Peritubal and periovarian adhesions may be present. And stage 4, it is severe with multiple implants, ovarian endometriomas, and there may be many dense adhesions. Coming to the symptomatology, endometriosis may be asymptomatic in many women. Even in more advanced diseases also, in many cases of ovarian endometrioma and all, they are asymptomatic. And some women with extensive disease have no pain at all, whereas some others with only minimal to mild disease may experience severe pain too. So actually we think that endometriosis means the main thing is dysmenorrhea. Dysmenorrhea always it is a cardinal feature of endometriosis, we have learned. But in in practice, when we get many cases of endometriosis are being diagnosed only on the during infertility workup and all, these are getting diagnosed. So that is it. And regarding pain, if it is present, it may either be cyclic or chronic. And the possible mechanisms causing pain in patients with endometriosis include all the local peritoneal inflammation, as we have discussed earlier, deep infiltration with tissue damage, adhesion formation, fibrotic thickening, and collection of shed menstrual blood in endometrial implants, resulting in painful traction with a physiologic movement of tissues. We can categorize the pain in endometriosis as 4 Ds, depending on the location. It is present. Dysmenorrhea, especially suggestive of endometriosis, if it begins after years of pain-free periods, often starts before the onset of menstrual bleeding and continues throughout the menstrual period, and it is less responsive to NSAIDs. And this pain is thought to be more severe in comparison with primary dysmenorrhea, and have got a positive correlation with the severity of dysmenorrhea and the risk of endometriosis. And nowadays, many cases of the primary dysmenorrhea is getting diagnosed as endometriosis. Then next is dyspareunia. Dyspareunia, actually, it is related to rectovaginal septum involvement or maybe the uterosacral ligament disease. And it is less commonly associated with ovarian endometriomas. Here, during intercourse, the tension on the deceased uterosacral ligaments may be the trigger of this pain. Next is dysuria. Although a less frequent symptom of endometriosis, bladder complaints of this painful urination as well as cyclic urinary frequency and urgency may be noted in endometriosis. But concurrently, we have to rule out the UTI by negative urine cultures. Next is dyschezia, that is painful defecation. It typically reflects the rectosigmoid involvement with endometriotic implants. Symptoms may be chronic or cyclic, or may be associated with constipation, diarrhea, or cyclic hematochezia. And we can also see a non-cyclical pelvic pain, chronic pelvic pain, which is the most common symptom associated with endometriosis. Approximately 40 to 60% of women with chronic pelvic pain are found to have endometriosis at the time of laparoscopy. The focus of chronic pain may vary from women to women. If the rectovaginal septum or uterosacral ligaments are involved with the disease, pain may radiate to rectum or lower back. Alternately, the pain radiating down the leg and causing cyclic sciatica may reflect a posterior peritoneal endometriosis. And next is most commonly seen in endometriosis is infertility. The mechanism or causes are multifactorial. In a nutshell, we can categorize the causes as such: anatomical changes, immunological factors, endocrine dysregulation, and implantation defect. Now let's see how these causes can lead to infertility. Endometriosis can lead to adhesions within the abdominal cavity caused by all the inflammatory reactions. Peritubular and periovarian adhesions, as well as tubal wall fibrosis, can lead to a decreased tubal motility and decreased access to the ovulated oocyte, interrupting the ovum pickup. Minor adhesions that are less obvious include the intratubal adhesions that can lead to blockage of fallopian tubes and the inability to transfer oocytes to the uterine cavity. So these anatomic distortions can only be adequately diagnosed at the time of surgery. Immunologic factors contributing to infertility are, as discussed earlier, we know that several components of peritoneal fluid, such as macrophages, growth factors, cytokines, etc., are known to be present at different levels in endometriosis, creating an inflammatory milieu. And its impact will lead to impaired fertilization, possibly lead to increased sperm phagocytosis and decreased sperm motility. There may be compromised oocyte quality. There may be compromised oocyte quality, increased granulosa cell apoptosis, and implantation defects can be seen due to decreased integrin H3 and increased embryo toxicity. Another contributing cause is endocrine dysregulation. Here, endocrinologic abnormalities associated with anovulation, abnormal follicular development with impaired follicular growth can be seen. Disturbed LH surge patterns, premenstrual spottings, luteinized unruptured follicle syndrome, these all can be seen. And in severe endometriosis, patients experience a compromised oocyte maturation too. And next is implantation defect. It involves any abnormality during the attachment, intrusion, and invasive phases of implantation, including destabilization of endometrium as well as the survival of the embryo proper. It has been reported that HOX-A10 and HOX-A11, which are normally upregulated in the secretory phase of endometrium, are not upregulated in women with endometriosis. And a recent study has shown that HOX-A10 directly regulates the integrin H3 subunit. As this H3 integrin, a cell adhesion molecule, it is a cell adhesion molecule of the endometrium expressed at the apical surface of the luminal epithelium, and it's important for embryonic attachment. So its down regulation would negatively impact the implantation. So the changed levels of this integrin during the window of implantation can have a negative impact on infertility in patients with endometriosis. And increased free radicals too. Increased free radicals may also decrease the oocyte and embryo quality by creating a toxic environment for the developing embryo. Glutathione peroxidase and catalase have shown to be aberrantly expressed and to lose their typical fluctuation during the menstrual cycle in women with endometriosis. So this may affect the environment of endometrium by changing the levels of free radicals. And other factors negatively affecting the free radical concentration in the uterine environment for the developing embryo are elevated levels of manganese and copper superoxide dismutase within the endometrium of affected women. So all together, they will contribute to implantation failure at the level of embryonic attachment, survival, and embryodecidual signaling. Going on to the differential diagnosis, the symptoms of endometriosis are non-specific and may mimic many disease processes. Gynecological causes to be ruled out are PID related, all the tubular abscess, salpingitis, endometritis, and hemorrhagic ovarian cyst, ovarian torsion, primary dysmenorrhea, and degenerating leiomyoma. Other non-gynecologic causes like cystitis, chronic UTI, renal calculi, irritable bowel syndrome, diverticulitis, mesenteric lymphadenitis, and other musculoskeletal disorders. Depending on the symptoms, we have to rule out. Moving on to the pelvic examination. In many women with endometriosis, no abnormality is detected during the clinical examination. But if the vulva, vagina, and cervix should be, if that is involved, we may get clinical signs accordingly. But usually on visual inspection, no abnormalities are found, and exception is surgical scars where you can see the endometriosis on episiotomy scar or LCA scar. Then on speculum examination also it reveals no signs of endometriosis actually. Occasionally bluish or red powder burn lesions may be seen on cervix or the posterior fornix of vagina. But on bimanual examination, this will reveal all the anatomic abnormalities suggestive of endometriosis. Uterosacral ligament nodularity and tenderness may reflect an active disease or scarring along the ligament. In addition, an enlarged cystic adnexal mass may represent an ovarian endometrioma, which may be mobile or adherent to the other pelvic structures. In more advanced diseases, uterus is often in a fixed retroversion and the mobility will be restricted. And it is termed as actually frozen pelvis, what we call as frozen pelvis. Then actually on clinical examination can give us a false negative result. So the next step in diagnostic workup is always a medical imaging. And no imaging modality can detect endometriosis accurately enough to replace a surgical visual detection and biopsy before diagnosis. So always the gold standard for diagnosis remains laparoscopic visualization of lesions with histology confirmation, but it's not always possible, right? So we can go for USG, either a TVS or PRS, transvaginal or transrectal, depending on the symptoms. The typical ultrasound features of an endometriotic ovarian cyst is described as ground glass echogenicity of the cyst fluid, 1 to 4 locules, and no solid parts. Actually, here in TVS, it has got limitation. It can only pick up the endometrioma, that is the chocolate cyst only, but not the peritoneal endometrial implants. So we cannot say that if the chocolate cyst is not present on USG, we can't rule out the whole endometriosis, because we can't rule out the endometrial implants or other nodules also. If nodules are suspected, you can go for a transrectal sonography. If you're suspecting cases on endometrial nodules on rectovaginal septum or uterosacral ligaments. So other imaging techniques, CT and MRI actually can be used, but they are not considered as first-line imaging modalities because of the high cost and their radiation exposure. Anyway, MRI has got a good sensitivity and specificity for the diagnosis of deep endometriosis and endometriomas, but the value in addition to TVS is really limited here. Blood test, actually there is no specific blood test for diagnosis of endometriosis, but obviously to exclude other causes of pelvic pain, laboratory investigations can be undertaken, like CBC, urine routine microcultures, vaginal cultures, and cervical swab may be obtained to exclude all the infections that may cause a pelvic inflammatory status. And another one which we often give is serum CA-125, which is a glycoprotein from coelomic epithelium, and it is common to most non-mucinous epithelial ovarian carcinomas. These are significantly higher in women with moderate or severe endometriosis, but it may be normal in some mild and minimal cases too. But compared with laparoscopy, the measurement of serum CA-125 levels has no value as a diagnostic tool. And when we give a serum CA-125, it's a marker for ovarian CA, but in ovarian CA cases and all, the concentration will be really very high, maybe more than 200 and all. But in endometriosis cases, it may be within or around 100. If it is crossing, if it is above 200 and all, we should suspect a ovarian CA. Then moving on to laparoscopy. Laparoscopy is considered as the gold standard. A positive result will confirm, but a negative result doesn't exclude the possibility of endometriosis. And visual inspection is usually adequate, but histology of any one lesion is ideal. And microscopically, this implants consist of endometrial glands and stroma with or without chemocytin-laden macrophages. Now coming to the Ayurvedic perspective, endometriosis cannot be correlated to any single disease of Ayurveda, because in Ayurveda, the classification is not based on the histological changes as as in the modern system of medicine, but on the clinical presentation. And, one of the reference in Charaka Samhita, I would like to highlight this. Yoga ye apyatra na uddishta bahutvan namarupataha तेषामपि एतदेव स्यात् दोषादीन् वीक्ष्य भेषजं दोषदूषनिदानानां विपरीतं हितं ध्रुवम् उक्तानुक्तान् गदान् सर्वान् सम्यक् युक्तं नियच्छति. Here Acharya says that the disease which is not mentioned in the classical text or which you can't name them, the way you can start the disease or the way to treat the disease is by understanding them according to dosha, dushya and nidana. And also he says that the treatment should be opposite to the causative factors and it should be hita for the body or conducive for the body. The main pathophysiologic mechanism here we can consider as the ashaya apakarsha gati, which leads to an atypical symptomatology where the clinical features may not align with the expected dosha involvement and contribute to symptom mismatch and diagnostic ambiguity. Here the dosha involvement is probably the vada pradhana pitta kavanubandha dosha along with rakta dushti. Apana vada vaigunya contributing to the endocrine dysregulation. Pitta rakta dushti can be appreciated as a subclinical peritoneal inflammatory status as we have discussed earlier. And here there is always an abhyantara pittapada as noted here in endometriosis, and involvement of kava can be appreciated by the growth and proliferation of implants as well as the formation of adhesions. Next, some of the diseases having comparable features with endometriosis are Acharya Sushruta's vata dominant univyapats like Udavarta, Vandya, Vipluta, Paripluta and Vatala. If it is predominant with features of dysmenorrhea, can be considered as Udavarta, and features of infertility related considered as Vandya. Features of chronic pelvic pain can be considered at the level of Vipluta Yoni, and if the features of dyspareunia is prominent, then Paripluta Yoni Vyapat, and features of frozen pelvis we can consider as Vatala Yoni Vyapat, and even in some cases we get intermenstrual bleeding patterns are observed. There we can consider at the level of Vadacha Pradharatu. Coming to the Chikitsa aspect, the basic principle of Ayurveda is Swastasya Swastharakshanam and Adrasya Vigara Prashamanam. Swastasya Swastharakshanam is very important. And our acharyas have well mentioned the preventive aspect for all diseases, though in an indirect way. So it's one Vaidya's yukti that has to be applied to explore those aspects. That is, by means of Arthapati Pramana, that means we have to understand the relevant hidden meaning unexplained in the references. So if we go through, the Ayurvedic prevention for all diseases starts from Garbhadana. And this Garbhadana starts from the first day of Rajaswala Kala. And Acharyas have well mentioned the Rajaswala Paricharya, codes and conducts to be followed during menstrual period. Maybe our Acharyas years before itself, they had a long-term good insight about this retrograde menstruation proposed just in the mid-19th century by Samson. So, though there is a later scientists have noted, there is a physiological occurrence of retrograde menstruation, but even though there is a small grade of this retrograde menstruation, as proposed by later scientists, indulgement in activities contraindicated during Rajaswala Kala may contribute to its pathology where there is already a Vaigunya and a degree of Bala. Maybe that is the reason even why even Panchakarma therapies are not advised during this menstrual period. And now, in this current era of increased incidence of gynecological disorders, it's our duty to counsel the patients about the need for Rajaswala Paricharya and advise it at least with some modifications for prevention of endometriosis-like disorders. Moving on to the curative aspect. Nidana Parivarjanam, the definition of Chikitsa itself is Nidana Parivarjanam. Nidana Parivarjanam itself is the first and foremost in our Chikitsa. Here in endometriosis, all the general Nidana for Yoni Vyapat, that is Mithya Achara, that is Mithya Ahara and Vihara, Pradushtartava, Bija Dosha, and Deva, and use of Apatravyas. Apatravyas mentioned by Acharya Vagbhada. Apatravyas in the current context, the use of menstrual cups can be considered as an apatravya, because in many cases we are observing that we are getting such cases of endometriosis after using menstrual cups for 3 to 6 months. The menstrual pattern itself is really getting changed. So we need to avoid this apatravya, use of apatravya in the form of menstrual cups too. And obviously avoiding all the Rajaswalacharya contraindications, mainly Abhinga, Shirasnana, Vyayama, all strenuous activities which may increase the intra-abdominal pressure. And Dvida Upakrama, Pathya is one among the treatment, because Pathya itself is also a treatment. Rajaswala Pathya can be advised in cases of endometriosis. Pathya, in the sense, there is a specific diet recipe mentioned in Rajaswalacharya, that is Yavakam and Havishyanam. I used to prescribe my patients this Yavakam, that is Yava cooked in milk. So that can be used as a one-time meal, and we do get a good result on this. Then other Shodhana aspect, we can give Rechana and Basti. And Shamana aspect, we can opt for a Vatahara, Vatanulomana and Pitta line of treatment, and can incorporate all the Vata Chiyoni, Vyapat Chikitsa, Gulma Chikitsa, Pradara Chikitsa, and Pandya Chikitsa too. Actually, each cases are unique in their presentation, depending on the extension of involvement of Docha Dochyas. So, as said by Acharya Charaga, it's a Vaidya Sukti to initiate treatment, which is opposite to the positive factors and conducive for the body. Today, I would like to present a case that brings forward a vital clinical side, that surgery isn't always necessary when it comes to infertility linked with endometriosis. In fact, in certain situations, it may become a contributor, or it may become a risk factor for recurrence. As we have seen, we have seen during risk factors, previous surgeries are always a risk factor for endometriosis. Here, I would also like to emphasize that even though Chodhana Chikitsa is mainly indicated for when there are cases, an appropriate Shamana Chikitsa tailored can also give wonderful results. I would like to share a successfully managed case of subfertility with post-surgical recurrence of ovarian endometrioma. The patient is a 28-year-old female, Nali Gravida. She visited our Prasutanda Sriroga department in December 2022. She had approached for concerns regarding fertility. She had a history of histolaparoscopy and adhesiolysis, in which bilateral chocolate cyst of size 3 into 4 centimeter was punctured, and chocolate material was drained along with adhesiolysis done in April 2022, following the diagnosis of ovarian endometrioma during the infertility workup at a modern hospital. Her menstrual cycles were regular, occurring at 21 to 25 days interval, with 3 to 5 days of bleeding duration. The menstrual flow was assessed to have Vata-Chakra-Drushti Lakshanas. She reported to have mild lower abdominal pain, but it was not severe as to incapacitate her day-to-day activities. There is no history of coital difficulties, and no relevant family history was reported. On examination, of vitals were stable and the patient was lean. Body mass index calculated was 18. No abnormalities were detected on examination of breast, cardiovascular and respiratory system. Abdomen was soft and tenderness present on right upper and lower quadrants. External genitalia appeared healthy. vagina and cervix appeared healthy on first speculum examination too. But on bimanual examination, revealed our uterus to be retroverted, bulky, and fixed, associated with right adnexal tenderness. So here, when she approached me, these lakshanas were pointing towards recurrence of endometriosis, and I had suggested her a repeat USG, which revealed a bilateral. This were our surgical history. And then the repeat USG given revealed a bilateral chocolate cyst of size 2.9 into 2.3 centimeter. This is present in right ovary and adherent to the uterus, and in left ovary too, 2.1 into 2.1 centimeter cyst present with low level echoes and adherent to uterus, along with a bulky uterus, which was retroflexed with altered bimetrial echoes indicating isis. It also revealed a gallbladder polyp of size 7 mm on abdomen scan. So here, when I saw this gallbladder polyp, I had actually referred her to a surgeon for further evaluation of this gallbladder polyp. And as per surgeon's opinion, no further evaluation or interference was required at this size. And then we had started the treatment, and initial counseling was done with regard to the prognosis regarding our management. And then the patient was willing to undergo an OPD basis treatment. Shamana Chikitsa was opted. First of all, initially, as I have said, Nidana Parivarjanam itself was prescribed. That is all the Vatakara Ahara Vihara, and even she had a history of Vishma Ahara Sevana and all. I had asked her to correct that, all the untimely meals, then avoiding intake of all the Kadu Rasa, Lavana Amla Rasa, and all to avoid Ratri Jagarana and Mutra Vegadharana. Asked her to avoid all these, and along with the Rajasula Patya too. This Yavakam was prescribed to her during her menstrual cycles. Then actually she was prescribed in a phase-wise manner with kashayas like Gandharvastadi. These were the intervention given. I have chosen Gandharvastadi Kashaya, Dashamulam Kashaya, Trayantyadi Kashaya, Arogyavardhini Rasa, Danantravadi, Idaradi Lehya, etc., followed by a conceptual line of treatment, including Kalyanagavrita and Phalasarpis in a stretch of 3 months. And the patient got conceived in the cycle just after the conception line. Here is her report. You can see after treatment, she got conceived, and actually the success of a fertility treatment, it's not solely indicated by a positive pregnancy test, but rather it encompasses the process from the initial UPT test, positive test, to the achievement of a good pregnancy outcome, which was evidenced in the above mentioned case. She was also prescribed with a add-on as antenatal care of Balamula, Chirapaka and Phalasarpis during her antenatal period, along with the contemporary antenatal supplementation. The outcome is she had a full-term normal delivery. The baby was 3.08 kg. She delivered on November 17th at 3 p.m. Baby cried soon after birth, and no gross anomalies were detected. And then after this, follow-up scan was done postpartum in January 24. And this ensured a non-recurrence of endometriosis. Even though the pregnancy can lead to a temporary remission, this follow-up scan was done, and even the gallbladder polyp was evaluated, and this is an additional benefit achieved regarding the size of gallbladder polyp, which remained status quo for the past 1 year, where generally it increases in size up to 2 mm annually. So that is also an additional benefit achieved with our Shamana Chikitsa. Here, Gandharvastadi Kashaya is a common medicine we are using in Kerala. That is a combination of Gandharvasta, Chirivilla, Kashavishwa, Patyapunarnava, Yavashaka, Bhumitalehi. Actually, this is a wonderful Vatanulomana medicine. Can act as both Deepana and Pachana, and it has got properties like Deepana Pachana and Malashodhana property also. So always this can be used as a first line treatment. It's Anupana, Saindava and Gura. And next Kashaya opted was the Shamulam Kashaya, mentioned in Jwaradhikara by Shajaratnavali. It is Tikta Kashaya Madhura Rasa Pradhana with Uchnavirya. Excellent Kabanubandha Vatahara medicine it is. It can control the Chala property of Vata. Can act as Shula Prashamana and Shofahara. Studies have demonstrated that the Shamulam Kashayam has got potent anti-inflammatory and antioxidant properties, and this might have resulted in correction of the inflammatory mediators in this case. Then Trayantyadi Kashaya was opted, which was indicated in Vidrati Chikitsa. That is at Tikta Kashaya. It is of Tikta Kashaya Madhura Rasa Pradhana, which can act as a Grandhi Vilayana. It can act as Pakahara and Shodhahara. This is also an excellent combination to choose in Rakta Dushti, which is noticeable. Can also provide Rakta Prasadana. And then Arogya Vardhini Rasa was prescribed, which is of Tikta Kadu Rasa Pradhana, Kinchidushna Virya drug, and it can act as Vadakava Shabana. This also, Arogya Vardhini Rasa also, it can act as Deepana Pachana at both Koshtagada and Dhatukada levels. So, here by virtue of this, of its Stodha Shodhana and Leghna properties, might have helped to tackle the adhesions, which might have led to either subfertility, interrupting the ovum pickup and all. And Dhanantrayapati was used, it's an excellent combination for Vatanulomana. As the name indicates itself, this medicine is really a gift from Lord Dhanantari, and it has got multi-systemic action. Idaryadi Lehya I have chosen in the Brahmana phase because it possesses Balya Brahmana, Rasayana and Juniya properties. Then conceptual line of treatment incorporating the Snehapana with Kalyanaga Grita in proliferative phase, and Phalasatvis was given in the luteal phase. Might have created a favorable environment for invasion. And actually, by this case, I would like to have a discussion whether this case actually didn't need a surgery, but we got this case means just after the surgery and all. Even though she had undergone that conservative surgery, it eventually resulted in recurrence, right? And the patient remained subfertile still. But phase-wise Ayurveda Shamana Chikitsa could address the multifaceted causes of endometriosis that have led to subfertility, including the oocyte quality, embryo development, and the interaction between embryo and endometrium. Embryo and endometrium. And a postpartum follow-up scan confirmed the absence of endometriosis recurrence, and no increase in size of gallbladder polyp was observed. And I hope let this case remind us of the strength of Ayurveda Chikitsa frameworks, especially when we approach treatment with clarity and compassion. So always trust our signs, follow Aptopdesha, and we'll get result. So with this, I would like to conclude my session. Thank you all for your patient listening. These were the references.
जी, बहुत बहुत धन्यवाद डॉक्टर प्रियंका। बहुत ही बढ़िया प्रेजेंटेशन, और मैं समझती हूँ कि सभी पार्टिसिपेंट्स के लिए ये बहुत ही ज़्यादा मार्ग निर्देशक का काम करेगी। और आगे वो जो इस प्लेटफॉर्म का एक उद्देश्य है कि बहुत सारे चिकित्सक हम श्रेष्ठ निर्माण कर सके, जिससे भारतवर्ष को लोगों की आयुर्वेद के माध्यम से सेवा कर सके। तो मैं आपका बहुत बहुत धन्यवाद करती हूँ। और आगे कोई प्रश्न है आपका पार्टिसिपेंट में से, तो मैं उनको आमंत्रित करती हूँ कि आप अपना प्रश्न पूछ सकते हैं। आपका हैंड रेज करिए, हम बारी बारी आपको आमंत्रित करेंगे। और इफ यू वांट टू राइट अ क्वेश्चन इन चैट बॉक्स यू कैन। जी डॉक्टर रजनीश जी, नाइस प्रेजेंटेशन। बिल्कुल मॉडर्न वाला रिव्यू भी बहुत अच्छी तरीके से शॉर्ट एंड स्वीट फॉर्म में बताया, और साथ में आयुर्वेद के सभी संभावित बिंदुओं को समाहित करते हुए डॉक्टर प्रियंका ने लिया है। वो सच में काबिले तारीफ है।
Thank you.
ट्रीटमेंट ऑफ द ट्रीटमेंट फॉर ब्लैडर इंडोमेट्रोसिस, डॉक्टर एक मिनट, डॉक्टर सुभाषिनी राज ने पूछा है डॉक्टर साहब।
Bladder endometriosis, actually, I have not come across such a case of bladder endometriosis, but still we can apply these principles like the Kabahara combinations can be chosen. Always each, I have already said in presentation that each case is unique in its presentation. So we need to tackle according to the phases like dosha avasthas, like initially going for a Dipana Pachana treatment, which can, depending means if there is a Pitta predominance, you can either go for a Sudarshana Churna or Gulchyadi combinations you can go for, or Shodhana combination, Malshodhana combinations like even Gandharvastadi can be chosen as first line. And following that, Vyadhihara treatment by mainly the adhesions need to be addressed. So in that way, Pitta Kabahara combinations can be chosen.
जी बिल्कुल सही बात बताया आपने कि सभी की एक जैसी ट्रीटमेंट नहीं हो पाएगी। हम उसमें दोषानुबंध और एसोसिएटेड सिम्टम्स, जैसे आज ही मेरी क्लास में मेरे स्टूडेंट्स पीजी स्कॉलर्स के साथ बात हुई कि इंडोमेट्रोसिस जैसे केसेस में जो लंबे समय से है, जो काफ़ी दर्द से परेशान है ना, जैसे इनफर्टिलिटी नहीं है वैसे ही है ना इंडोमेट्रोसिस इन अनमैरिड। तो वहाँ भी मैंने देखा, या जिसकी 1 और 2 चाइल्ड जो भी अपनी रिप्रोडक्टिव लाइफ में चाहिए वो उनके पास है, उसके बाद है अगर, तो ओनली रजस्वलाचर्या इज सो मच इफेक्टिव, है ना। तो मैं एक बार रिपीट भी कर देती हूँ, हो सकता है कुछ नए बच्चे, नए पार्टिसिपेंट्स जुड़े हो, कि रजस्वलाचर्या मानी सामान्य भोजन को छोड़कर, है ना, जो सामान्य रूप से जहां जहां जो भी खाया जाता है उसको छोड़कर मेंस्ट्रुएशन स्टार्ट होने के बाद, शुरू होने के बाद पहला, दूसरा और तीसरा दिन जो रजस्वला में भोजन बताया गया है, सघृत शाली ओदन यानी घी के साथ शाली चावल, रक्तशाली त्रिदोषामक के वो ले सकते हैं, और क्षीर संस्कृतम यवान्नम, दूध में पकाए हुए जौ। यानी हमारे पास 4 चीज है, घी, दूध, शाली चावल और बार्ली। उसमें से आप कुछ भी बना के ले सकते हैं, जैसे घी चावल, घी बुरा चावल, चावल की खीर, जौ के दलिए की खीर, जौ की रोटी पे अच्छा घी लगाकर दूध के साथ। मीठा दूध या फीका दूध हो सकता है। अगर पेशेंट डायबिटिक है तो ओनली विदाउट एनी मिश्री, सिर्फ बार्ली को घी और दूध के साथ लेना चाहिए और खीर के फॉर्म में भी ले सकते हैं। तो मैंने अपने कुछ पेशेंट्स और कुछ मेरे स्टूडेंट्स के उसमें देखा कि विदाउट एनी अदर ड्रग भी बहुत अच्छा रिजल्ट है, और अगर हम कुछ और चला देते हैं तो बढ़िया रहता ही है। तो और दूसरा कि आर्तव की सभी बिंदुओं की अगर परीक्षा की जाए और उसके बाद भी वहाँ कुछ ऐड किया जाता है, करेक्शन किया जाता है, तो भी बहुत अच्छा रिजल्ट मिलता है। और डॉक्टर प्रियंका ने बिल्कुल सही बताया कि हम एक ट्रीटमेंट तो नहीं कर पाएंगे, मगर अगर हम साथ में मिलने वाले एसोसिएटेड सिम्टम्स और रजस्वलाचर्या का पालन करवाते हैं तो कहीं ना कहीं धातु साम्य होता है और वो वहाँ बहुत अच्छा रिलीफ इफेक्ट को प्रदर्शित करता है। डॉक्टर प्रीति गर्ग, आप पूछ रही है ट्रीटमेंट ऑफ द स्कार इंडोमेट्रोसिस आफ्टर लेप्रोस्कोपी।
मैम नमस्ते।
जी नमस्ते बेटा। हाँ जी।
मैम मेरा एक पेशेंट है, उसमें क्या हुआ, स्कार ये हुआ था, लेप्रोस्कोपी हुई थी एंडोमेट्रियोसिस सिस्ट के लिए, लेकिन अभी 2-3 महीने ठीक रही पेशेंट, लेकिन अभी क्या हो रहा है, उसका नाभि से ना ब्लीडिंग हो रहा है, मतलब पीरियड आने से पहले पहले नाभि से ब्लीडिंग हो रही है, मतलब वो ये स्कार एंडोमेट्रियोसिस है मैम। तो उसमें कुछ लोकल दे सकते हैं क्या मैम?
अगेन बस वही बात है डॉक्टर प्रियंका। हेलो डॉक्टर प्रियंका।
Hello, ma'am. Can you hear me?
जी जी बेटा बताइए।
Ma'am, actually, my network was down, ma'am. Can
अच्छा।
you please repeat, ma'am?
डॉक्टर प्रीति एक बार
हाँ
फिर
मैम।
या
मैम मेरा एक पेशेंट है, उसका एंडोमेट्रियोटिक सिस्ट के लिए उसने लेप्रोस्कोपी कराई थी, सिस्ट तो हट गया, एंड उसको फिर उसके बाद 2-3 महीने बाद अभी नेबल से थोड़ा ब्लीडिंग हो रहा है, मतलब पीरियड आने के 2-3 दिन पहले नेबल से ब्लीडिंग होती है। तो वो तो स्कार एंडोमेट्रियोसिस है, तो उसमें मैम मैं मतलब दे रही हूँ इंटरनल मेडिसिन, लेकिन कुछ लोकल के लिए भी दे सकते हैं जिससे जल्दी थोड़ा ठीक हो जाए।
Um, actually, bleeding from
हेलो।
बेटा ब्लीडिंग फ्रॉम नेवल, नाभि
फ्रॉम
नाभि
नेबल,
से।
हाँ नेबल।
Nabi se.
जी जी।
यस मैम।
Scar, but there is probability of scar endometriosis in that case, no? Is
यस
it?
मैम, यस मैम।
So, actually, scar endometriosis cases also, I mean, I have not come across such cases, scar endometriosis, but it is becoming common nowadays. We may try for Basti Chikitsa in those cases, Vrechana followed by a Basti. Initially, always Pitta involvement should be tackled, and then further a Basti can give a good result, I think. And local application, I don't know. Local application actually in endometriosis cases, I used to opt for Shirabala Taila Adhunabi Pichu I used to give, and which can control the pains and all in cases. I used to start in that secretory phases and all. So Shirabala Adhunabi Pichu can be opted.
ओके मैम, ओके। थैंक यू मैम।
बहुत बहुत धन्यवाद डॉक्टर साहब। डॉक्टर प्रीति एक बार है ना ये आप करके देखिए, और हम जो यहाँ एनआईए में बहुत डिटेल हिस्ट्री लेते हैं है ना,
यस मैम।
वो करिए, निदान परिवर्जन करिए, है ना, और वहां आपको एक दोष को इंगित करते हुई बातें समझ में आएगी, है ना, जब हम यहाँ एनआईए में करते ही हैं।
यस
और
मैम।
जो मैम ने कहा वो भी हमें साथ में युक्ति युक्त संगत रूप से लागू करना पड़ेगा, तो मुझे लगता है कि अच्छा रहना चाहिए, क्योंकि पिछली बार शायद आप थे तब या उससे पहले एक इनफर्टिलिटी ट्रीटेड केस में एलएससीएस स्कार में इंडोमेट्रोसिस आफ्टर 4 years ऑफ ट्रीटमेंट हुआ था।
ओके
तो
मैम।
पहले एक साल तो इंडोमेट्रोसिस स्कार का सुमन जैन मैडम ने ही एक बार उसका फिर से ओटी में लेके किया, और बाद में रजस्वलाचर्या पे डाला है, और अभी 3 साल से बिल्कुल ठीक है, 3 या पता नहीं 2.5 साल से।
ओके मैम, मैं ट्राई करूंगी मैम ये वाला चीज, और मैम ने जो बोला वो भी देखूंगी, करूंगी मैम।
और
उसके बाद
रजस्वलाचर्या
रिजल्ट
पे तो डाल ही
बोलती हूँ।
दो, है ना।
यस मैम, मैंने रजस्वलाचार्य और वो जो आपका इनफर्टिलिटी प्रोटोकॉल रहता है ना मैम, मैंने वो पूरा महीना फॉलो करने को दे दिया उसको अभी।
आफ्टर डूइंग रजस्वलाचार्य हाउ मीन्स हाउ मेनी ऐसे कुछ रहा
मैम
कि
वो पेन वगैरह नहीं है पेशेंट को,
अच्छा
और मैंने रिपोर्ट कराया है एंडोमेट्रियोसिस जो पहले थोड़ा सा अडेर था, वो जो इसका ओवरीज वो थोड़ा कम हुआ है, लेकिन
अच्छा
ये नया में आया है। मतलब पहले नेबल पे कुछ नहीं था मैम, अभी 2 महीने से नेबल से ब्लीडिंग हो रहा है, और नेबल में हल्का स्वेलिंग आने से स्वेलिंग होता है, और फिर ये सिक्रेटरी फेज में बढ़ता है, ब्लीडिंग होता है, फिर नॉर्मल हो जाता है।
सही है। तो फिर शोथ जनन सारे निदानों को एक बार रूल आउट करिए,
यस
है
मैम।
ना। कहीं ना कुछ में भी, है ना, ऐसा कुछ आदत हो या विरुद्ध आहार, दो चीज को देखिए बेटा, क्योंकि मैंने अपने जीवन में ये दो चीज देखी कि ये, है ना कहीं मिलती है, विरुद्ध आहार और कहीं ना कहीं शोथ कारक आहार, है ना।
यस मैम,
Yes.
मैं एक बार और अच्छे से हिस्ट्री लेके देखती हूँ मैम।
सोने का और उठने का समय प्रॉपर करवाइए, है ना, तो ये भी
यस
बहुत
मैम।
ज्यादा हेल्प करता है।
Yes,
ओके
ma'am.
मैम।
What you've said is really right because Nidana Parivarjanam itself is a chikitsa. Actually, deriving that Nidana Panchakas itself, we can correct the whole thing. All the diet lifestyle diseases will come back to normal mean.
जी डॉक्टर साहब, बिल्कुल, बहुत बहुत धन्यवाद। डॉक्टर सुमा जी पूछ रही है ट्रीटमेंट फॉर एसाइक्लिकल क्रॉनिक पेल्विक पेन वेयर यूएसटी इज नॉर्मल बट पेन इंक्रीजेस मिड साइकिल यानी ड्यूरिंग ओव्यूलेशन विथ कॉन्स्टिपेशन। डॉक्टर प्रियंका, आप चैट बॉक्स में भी देख सकते हैं। हेलो डॉक्टर प्रियंका।
Ma'am, my network is down here.
जी
Actually, it was,
कैन यू
ma'am, you were discussing about mid-cycle pain, right, ma'am?
कैन यू सी द चैट बॉक्स बेटा?
No, ma'am. Right now,
Okay, I have
you didn't see,
again
ma'am.
copy paste
Ha, ha.
the question
Okay,
for
okay.
Doctor
Treatment of
Sumaji.
cyclic.
Yes, yes.
Okay, okay, ma'am. Treatment of cyclical chronic pain. Okay. Hearing this history itself, there is probability of endometriosis in this case, but we can't go for such an invasive procedure to diagnose like laparoscopy and all. Here, I had such similar cases. There may be chances of increased prostaglandins and all. So there we can give initially Vata Hara combination, mainly like Gandharvasthati Kashaya can be opted, and even you can give Vata Pitta combination can be chosen, and in luteal phases, it should be corrected accordingly with phase-wise treatment, like Vata Pitta Shamana treatment, like Drakshadi Kashaya and all can be given to control that. And even Dashamulam is an excellent combination to give during that mid-cycle itself. And even in Gandharvastha Eranda Taila, as a mid-cycle Virejana we can give. That is also an excellent option to give. So such things and even Avipatti Churna can be chosen in such conditions as a mid-cycle Virejana. So it depends on the condition of the patient, whether she is dominant, the dosha dominance should be assessed on the associated Pitta Kabanu Bandha should be assessed in detail, and then we have to choose combinations accordingly. Even the Kalpana is very important. It's not about only the medicines, like either you can go for Kashaya or even the Thaila. These Kalpanas actually acts in its own way, right? So we have to choose medicine wisely according to the condition or according to the dosha avastha of the patient. A mid-cycle virechana can be opted.
जी बहुत बहुत धन्यवाद। Dr. Suma, shall we plan for the Erand Moola Basti?
Yeah, yes, ma'am. Eranda Moola Basti and Dashmula Kshira Niroha Basti are opted in cases of endometriosis, ma'am. We used to give, and we are getting results for that. Dashmula Kshira Basti in STM college, ma'am used to give that, and even I used to follow this Dashmula Kshira Niroha.
जी डॉक्टर साहब, बहुत बहुत धन्यवाद। और डॉक्टर गीता कुमावत जी, आपका भी बहुत बहुत धन्यवाद। मैं आप सभी पार्टिसिपेंट्स को भी कहना चाहूँगी कि आप में से भी, है ना, जैसे डॉक्टर गीता कुमावत को डॉक्टर साहब सर्जरी से एमडी एमएस है, और मैंने उनको रिक्वेस्ट किया था कि बहुत बार, जैसे पिछली बार ये हुआ था कि हमारे पास कुछ नेटवर्क में दिक्कत है, आज थोड़ी सी कम है तो चल गया काम, मगर ज़्यादा हो जाती है तो कई बार स्पीकर महोदय या महोदया से बात करनी पड़ती है। तो इस ऑनलाइन स्टेज को, प्लेटफॉर्म को संभालने के लिए मुझे किसी की आवश्यकता रहती है, तो मैंने डॉक्टर गीता से निवेदन किया था, और आप प्रत्येक लेक्चर में आपकी उपस्थिति से बिल्कुल चिंता सी कम हो जाती है। डॉक्टर गीता, बहुत बहुत धन्यवाद, क्योंकि आप जैसे लोग साथ में आके आधार स्तंभ की तरह खड़े हो जाते हैं, तो कहीं ना कहीं 10 साल से ये व्याख्यान माला निःशुल्क रूप में चल रही है और बहुत सारे लोगों को लाभान्वित कर रही है। और डॉक्टर प्रियंका, विश्व आयुर्वेद परिषद की ओर से मैं आपका तहे दिल से धन्यवाद करती हूँ कि आप हमारे निवेदन पर यहाँ आए और आपने अपना वक्तव्य दिया, और इसके माध्यम से अभी YouTube पे भी मैं इसको अपलोड करूंगी, बहुत सारे लोग लाभान्वित होंगे। और बहुत सारे मुझे बाद में भी मिलते हैं, जैसे अभी मैं कुरुक्षेत्र गई थी तो वहाँ एक पीजी स्कॉलर मुझे अपनी रजिस्टर बता रहा था, डॉक्टर प्रेरित, कि देखिए मैडम, मैंने डॉक्टर तेजा का जो डर्मेटोलॉजी के ऊपर व्याख्यान है पूरा उसको सुनकर उसके नोट्स बनाए हैं, और मुझे व्याख्यान बहुत पसंद है। उन्होंने भूतपूर्व पहले हुआ डॉक्टर तेजा का व्याख्यान भी बहुत ध्यान से सुना था और उसके भी नोट्स बनाए थे, तो मुझे बहुत ही अच्छा लगा कि अ, मुझे बाय चांस चेहरा थोड़ा ध्यान नहीं था, मगर उसने तुरंत ही मुझे पहचान के, अच्छा मैडम वो आप वो है, मैंने कहा जी, और कहते हैं वो बहुत अच्छी व्याख्यान माला है और मैं उससे बड़ा लाभान्वित हो रहा हूँ, और मैं पूरी कोशिश करूंगा कि मैं चिकित्सा के माध्यम से भारत के लोगों की सेवा कर सकूं। तो कहीं ना कहीं बहुत ही ग्रेट अंदर से लगता है कि प्रयत्न, परिश्रम निष्फल नहीं जा रहा, किसी के तो उपयोग में आ रहा है। तो आप भी आगे आकर अपना योगदान दे सकते हैं, कोई चिकित्सकीय अनुभव सुना सकते हैं, जैसे बहुत बार डॉक्टर किमाया, डॉक्टर नाम में एक दो भूल गई, जो लगातार रेगुलर रूप से ज्वाइन करते हैं, है ना, डॉक्टर चंद्रकला भी है, डॉक्टर उषा होला भी है ना, तो अच्छा लगता है कि हाँ, कहीं ना कहीं आपका व्यक्तित्व और आपका प्रेरणादायी एटीट्यूड से हम बहुत सारों को और भी प्रेरित करेंगे, और कहीं ना कहीं भारत में आयुर्वेद राष्ट्रीय चिकित्सा पद्धति घोषित हो, क्योंकि राष्ट्रीय चिकित्सा चिकित्सा पद्धति घोषित होने से भारत के लोगों की पहली चॉइस में आयुर्वेद आ सकता है। और उस दिन मैं समझती हूँ, मेरी समझ छोटी सी हो सकती है, मगर मुझे ऐसा लगता है कि उससे आयुर्वेद के अच्छे दिन आएंगे और स्वास्थ्य के भी अच्छे दिन आएंगे, क्योंकि लगातार हम कई बार सोचते हैं ना, ऐसे बोलते भी है बहुत सारे मंचों से कि देखिए लगातार मेडिकल कॉलेज की संख्या बढ़ रही है, डॉक्टरों की संख्या बढ़ रही है ना, लगातार रिसर्च करके और भी आधुनिक विज्ञान में भी कुछ ना कुछ आ रहा है, आयुर्वेद में भी आ रहा है, मगर मरीजों की संख्या, है ना, आतुरों की संख्या नहीं कम हो रही है। तो मुझे लगता है कि कहीं ना कहीं उसमें बहुत अच्छा हमें लाभ मिलेगा भारत के लोगों को, तो हम ऐसा अपना योगदान दे सकते हैं। जी डॉक्टर किमाया, नाइस सेशन, थैंक यू फॉर द डॉक्टर प्रियंका ऑल्सो। और जी डॉक्टर कुमावत, गीता जी, आपका भी बहुत बहुत धन्यवाद, और पुनः सभी का, अच्छा बलजोत जी मैडम भी है, वेलकम बलजोत मैम। और फॉर स्कार एंडोमेट्रोसिस, जी मैम, मैं आपके मुंह से ही सुनना चाहेंगे, बलजोत मैम प्लीज। ओवर टू यू।
नमस्कार सभी को।
जी जी जी, नमस्ते।
तो मैंने कि अभी ज्वाइन किया था तो मुझे डिटेल मालूम नहीं क्या क्या डिस्कस हुआ, तो मुझे ऐसे ही ध्यान आया कि उसमें हम थोड़ा सा जैसे क्षार तेल के साथ में या पित्त शामक जो ऑयल है उसके साथ में नाभि पूरन भी कर सकते हैं, और वो उसी का ही जैसे मंजिष्ठादि जो रक्त पाचक वाले जो द्रव्य हैं उनका भी क्वाथ बना के उससे भी परिषेक कर सकते हैं। तो इसमें भी थोड़ा रिलीफ आता है। मैंने एक लेक्चर भी सुना था, उसमें वो महाराष्ट्र के हैं, मुझे अब याद नहीं आ रहा है, तो वो ये करते हैं, तो उससे भी उनके पेशेंट्स को काफी रिलीफ मिला है।
जी बिल्कुल सही कह रहे हैं डॉक्टर साहब, क्योंकि मैंने जैसे हम लोग नाभि पूरण बताते हैं या नाभि में सिर्फ ऑयल एप्लीकेशन बताते
जी
हैं,
जी मैम।
तो जैसे हमारे रिलेटिव्स में एक व्यक्ति ने ऐसे ही घर में बातचीत होती है ना, तो
जी
उन्होंने
मैम।
सिर्फ एरंड तेल नाभि में लगाने के लिए कहा और विद इन सम 10 डेज ही उसका काफ मसल पेन जो पिंडिकोद्वेष्टन हम लोग कहते हैं वो बिल्कुल ठीक हो गया।
जी
तो सही में नाभि प्रभव स्थान है और नाभि में ऑयल की एप्लीकेशन या नाभि पूरण है ना बहुत ही बढ़िया रहना चाहिए, और हमें बहुत सारे लोगों को ये चीज अनेक वात रोगों में करने की जरूरत है ना, कि जहां जहां भी वात का प्रधानता लगती है तो हम वहां कर सकते हैं। एक मैं और भी आपको बात याद करवाना चाहूंगी, डॉक्टर ईशा यहाँ राष्ट्रीय आयुर्वेद संस्थान में एनाटॉमी में असिस्टेंट प्रोफेसर है,
जी
और हमारे पास ही यहाँ यूजी पीजी पीएचडी सब कुछ यहीं राष्ट्रीय आयुर्वेद संस्थान से ही रहा। डॉक्टर ईशा
हाँ
का उन्होंने एक बहुत अच्छा पेपर प्रेजेंटेशन किया था, उसमें उन्होंने बताया था कि सिद्ध संप्रदाय में इसी तरीके से कर्ण का स्नेहन है ना, जो बाह्य कर्ण मिल दिखता
हाँ
है जो
जी
है ना, उसके अंदर स्नेहन बताया था, और वो शायद है ना अभी पेपर उनका पब्लिश हो गया होगा, क्योंकि वो तब मुझे कह रही थी कि मैम ये पब्लिश होने वाला है। तो
जी
हमने उसकी पीपीटी वगैरह भी फेसबुक पे डाली नहीं थी, है ना, और वो बहुत अच्छा अभी मिलना चाहिए पढ़ने के लिए भी, मैं उनसे पूछती हूँ। तो आप कर्ण का बाह्य स्नेहन है ना पित्त शामक तेल से तो बहुत ही अच्छा रहा, और मैंने कुछ पेशेंट्स में किया भी है, खासकर पोस्ट मेनोपॉज में जब वात का अ, वर्धन हो जाता है ना,
जी
तो उसमें वो सच में बहुत अच्छा काम करती है। जी बहुत बहुत धन्यवाद डॉक्टर बलजोत जी।
जी मैम, थैंक यू मैम।
जी वेलकम डॉक्टर। डॉक्टर प्रियंका, फिर से विश्व आयुर्वेद परिषद की ओर से आपका बहुत बहुत धन्यवाद। डॉक्टर सुभाषिनी जी आपका भी बहुत बहुत धन्यवाद। सभी पार्टिसिपेंट्स जो इस व्याख्यान की आत्मा है, सभी का तहे दिल से बहुत बहुत धन्यवाद कि आप यहाँ सभी पार्टिसिपेट्स करते हैं, अपनी अपनी जगह पे आयुर्वेद की सेवा करते हैं, और भारत के लोगों के बीच में आयुर्वेद की एक इमेज सुदृढ़ शास्त्र के रूप में जो है और होनी चाहिए उसके लिए लगातार प्रयत्नशील रहते हैं। तो सभी का बहुत बहुत तहे दिल से धन्यवाद। सबसे लास्ट में मैं शांति मंत्र ले रही हूँ, आप सभी म्यूट रखकर ही दोहराएंगे। ओम सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामया, सर्वे भद्राणि पश्यन्तु, मा कश्चित् दुःखभाग् भवेत्। ओम शांति शांति शांति। नमो नमः। विश्व मंगल की कामना के साथ अपने अपने हिस्सेदारी का कर्तव्य आप निभाते रहेंगे। बहुत बहुत धन्यवाद। डॉक्टर प्रियंका बहुत बहुत धन्यवाद।
वेलकम।